Well, I grew up on the East Coast. I was the daughter of a high school biology teacher and a biomedical researcher. My dad actually was the first MD PhD who graduated from the University of Virginia in 1966 or 67, I think. And he went on, actually maybe 67 or 68, he went on to do a pediatrics residency at UVA, but didn't finish because he ended up going to the National Institutes of Health as a commissioned public health service officer. This was during the time when biomedical research got a huge amount of funding because of the war on cancer. And so he was able to put himself into service for our country by working at NIH instead of having to go to Vietnam. So that was a huge boon for him to be able to follow his dream of becoming a medical researcher, but also for our family because we were able to keep my dad in the United States. And so we all moved to Maryland. I was 3 months old. And then so we grew up, I grew up there. I went to public school all the way through. And then I went to the University of Virginia for my undergrad. And when I went to college, my father said to me, "You can do anything you want, but you can't be pre-med." And he said that because he really didn't want me to miss out on a liberal arts education. He felt like that was so important. He was a classics major, and that was really something that he valued and wanted me to experience. And so I was an art history major, Japanese minor. I spent 4 years in college singing with an a cappella group, and I expanded my world. You know, I really felt like I had an amazing experience in college. But I got to the end of my third year. I had just spent the summer in Japan and realized that I was not going to be the international businesswoman that I had planned on being, that I didn't want to be doing art in the dark as an art historian, and I didn't want to do conservation in a museum and hate people for coming to see the art. You know, I just had all of these experiences that were very rich, but I sort of narrowed my focus. And I worked myself out all of these liberal arts careers and decided that I really wanted to go to medical school. And at that point, my dad was like, "Oh, that's wonderful. We'd love it if you went to medical school because now you're making your own choice, you know, not because I did it." And that actually was a really powerful transition for me. So I went to the University of Rochester because it was the only medical school that accepted me. Because I was a little strange, you know, the art history major. Why in the world would this woman want to go to medical school? Well, they saw something in me, and, you know, I went to medical school thinking, oh, I'll be an OBGYN because we know we need more women in that field. Little did I know that that was not true at all. There are plenty of women in OBGYN, but ironically, I ended up in surgery where there were very few women. And in fact, I think in my intern class, I know I was the only general surgery resident. There was one other woman in the program at the time when I started general surgery at UVA. I went back there for my residency. And there were a couple of other women that were in our intern class because they were in other surgical subspecialties like ENT and urology. That were a little more hospitable to women at that time. So I had some very close friends in my first year as being a resident that kind of bolstered me, and we were a team. That was my favorite year in training, honestly, my intern year. Closest friendships that I developed were in that year. You know, you're thrown into this situation where you don't really know what you're doing, and you're supposed to be a doctor, and you just basically have a piece of paper and a lot of knowledge but not a lot of skills and not a lot of understanding of how to take care of people. So, and some of those people that I was an intern with are still dear friends of mine. In fact, one of them lives in Seattle. So but I mean, the long and short of it is that I came to becoming a surgeon from a sort of a roundabout way, and I think it's really informed the kind of surgeon that I am that I didn't just go straight through high school and college and medical school knowing exactly what I wanted to do with my life. I used a lot of the experiences that I had to shape what I really wanted to get out of my life, what I really wanted in my career. And becoming an acute care surgeon, trauma surgeon, critical care doc was sort of out of all of that. You know, I really tried to embrace the most meaningful moments in my residency. And I found as I went through, I loved taking care of the sickest people. I loved the most difficult problems. I liked being forced to think with minimal amounts of information and not just think but do and try and treat people and fix their problems. And it was very rewarding, and I had some wonderful teachers along the way. So I'm really indebted to a number of people that immediately come to mind. My dad, my mentor in residency, and actually my boss now, because they really helped give me kind of that opportunity, but without too much direction, so that I had to kind of figure it out for myself. One of our faculty left, and he was doing all of the endocrine surgery here at Harborview. And I had not really done very much endocrine surgery since I'd been a resident, but I was the newest faculty member. And when he left, this opportunity opened up, and I said, I'd like to do that if there's somebody else that would do it with me. And so with my partner, Sam, or Bobby, we do all the endocrine surgery that is referred to our division, and it's been wonderful. It combines my interest in minimally invasive surgery because I get to do laparoscopic adrenalectomy, and that's a very specialized operation that not a lot of people do, actually. It's not something that's done very commonly, but I had done a number of them as a resident, and I had some of my partners at the other hospitals that are in the UW medicine system that do lap adrenals come over and help me as I was bringing that skill into my skill set again. And the same thing is true for thyroidectomy and parathyroidectomy. Those are the other two main procedures that I do as an endocrine surgeon. And because I just hadn't done that for a while, I brought some of my partners in to help me revamp my skills, be safe, be, doing the right kind of operation for the right person, making good decisions. And now that it's been a couple of years, I only turn to them when we have really difficult cases. But that's the way that we acquire new skills and we adopt new practices as professionals. I often tell my residents that you feel like you need to know everything when you finish your training. That you need to know how to do everything that you're going to be doing for the rest of your career, but that in fact is really not the case, because new procedures come up all the time and new opportunities like this come up all the time. And so for us to be able to adapt and to be able to take on different responsibilities and focus on different things allows us to serve our community in a way that we really need to do. Otherwise we wouldn't be able to do that here at Harborview. That was a wonderful experience. That was really the beginning of becoming an independent investigator. As an academic surgeon, it was a very unique opportunity. Surgeons are very busy clinically. Traditionally, we are at least 80% busy, and 20% is the most amount of effort that anybody can usually spend on research. That 3 years flipped it for me. I actually was able to spend 75% of my time doing research. And I'm indebted not only to my boss, Ron Mayer, who was able to figure out how to fund me, but also to my partners who put up with the fact that I didn't take call as much as they did and I didn't take care of as many patients as they did during that 3-year period. Because that really gave me the time, the protected time, we call it in academics, to focus on developing a research program. For me, the mentorship from Dave Flum, who continues to be my research mentor, was invaluable. He really forced me to think in a structured way about what are you doing, what are you interested in, how are you going to get to the questions that you want to answer, how are you going to answer them, and how are you going to build your research program. And he forced me to think on those terms. I'd never been confronted with that before. How are you going to structure all these grants that you're going to write to be able to fund your enterprise? And how are you going to get people to work with you? So it was really a challenge to go from, I used to work on somebody else's project and I found it very fulfilling and interesting, to come up not only with your own project, but a way to be able to tackle it and finish it. And because of that 3-year period where I had weekly meetings with other investigators, there were 4 of us in the program. We were all on the same sort of level, but from very different backgrounds. We had somebody who was a group health investigator who was an epidemiologist. We had somebody who was in the Department of Pharmacy, in the Pharmacy Outcomes Research Program. We had somebody who was in the Department of Pediatrics, and she was the only other clinician. So there were 2 of us that were clinicians and 2 of us that were pretty much 100% researchers. And that experience of getting to know those people and their goals and their motivations and their time constraints and their personal lives, all of that was really amazing to be able to go through that with other people. And my path was different from theirs because of where I'm headed now. I'm back to being 50% clinical, and then in July, I'm going to go back to 75% being clinical and 25% being research. So I'm going to flip it again. And I'm trying to figure out how to keep all those plates spinning as I move back into this other time management. But because of that K award, I was able to get additional funds from our department to be able to work on a project that I developed and a team that I structured that was multidisciplinary, not only in the Department of Surgery, but also in the Biomedical Health Informatics division. And so now I have experts that are devoted to user-centered design, informatics development, applications development. I have a PhD student that's been working with me for 1.5 years now, and now a second PhD student is going to come on board this summer. So we're really expanding our reach. We've been funded 3 times by internal funds. We call ourselves intrapreneurs right now. So we're getting funding from the institution in different aspects. One is from the Institute for Translational Health Sciences, the ITHS here at UW, and they're funding a preliminary study for us so that we can look at the outcomes that we're going to measure when we implement this project that we're initiating. And we also got some funds from the Center for Commercialization at the university because they do see the commercial potential for our project. And I was just informed this week that I just got another junior faculty award, not a mentored award. This is going to be me getting funds to mentor the people that I'm working with now. And that's through the Surgical Infection Society, which is an organization that I've been involved with for a number of years that I feel very devoted to, and I think really has a great mission, which is to try and develop ways to better prevent and treat surgical infections as they affect our patients. So the project that I've alluded to is actually the development and dissemination of a mobile app, and it's called Empower. I bet you were going to ask me about that. So Empower stands for the Mobile Postoperative Wound Evaluator. And this was conceived when my student Patrick came to me over 1.5 years ago now. This is almost 2 years ago. And he said, I heard that you are working on healthcare associated infections, and I'm interested in healthcare IT, and I understand you are too. Can we work together? And I said, well, what do you have in mind? And he described a project that actually was an extension of a lot of work that other people have done in infection and control in other institutions. And without trying to be rude, I basically said, I think that we can do something a lot more exciting. And how would you feel about developing an app for patients to take home on their smartphone as they're leaving the hospital after they've had surgery, that they can then use once they leave the hospital to be able to monitor their surgical wound for signs of infection and to communicate with their provider that actually knows the operation that they had. And he thought this was a compelling idea, but the first thing out of his mouth was, do you think we can do this in a year? Because I'm just doing a master's program. And I said, no, I don't think we can do this in a year, but I do think that we can do something important in a year and get this really started. And thankfully, he was willing to jump off the cliff with me. And for the next 12 months, we worked together with his advisor in biomedical health informatics, Bill Lober, who's a colleague of mine. And the three of us, with the help of a user-centered design expert, Andrea Hartzler, we were able to work together to bring this concept up. And we started with a needs assessment. We went to patients that had had surgical site infection, and we asked them, we said, what was your experience like? Did you feel like you knew what was happening when it was happening? What could we do better next time? Did you feel like your providers were responsive to your needs? What would you want to see if this were to happen over again, and how would you do it differently? And oh, by the way, what do you think about using an app? Would you be open to that? And do you think that there's any suggestions that you have about how we should create this? We also talked to providers. And we said, we know that you take care of wound infections, and we understand that you have patients that on occasion have these problems. How often do you think you see this? And do you really think that this is something that you do well? Who normally is the first one to discover that this is a problem? And do you think that's the way we should do it? The long and short of it is, everybody that we talked to thought that the app was a great idea. And we got some very interesting information from patients who basically said that they feel like the state of affairs right now is not like it should be. That they felt very alone, that they were unprepared, and even if they had been told what to expect, they really didn't have the skills to cope with what was happening to them once they left the hospital. And so we really feel like there's an opportunity here for us. So in the meantime, we worked on developing the app, and if you fast forward almost 2 years, now we actually have a prototype of the app that is fully functional, that actually will take pictures, will ask particular questions that are relevant to the development of surgical site infection, and we can get that data transmitted from any mobile phone, whether it's an iPhone or an Android phone or a Windows phone, and we can get that information into our secure encrypted database and then look at that information on the provider end to be able to make decisions about how to help people. So we're very excited that this is up and running. We're not quite ready for testing yet. We're still doing some usability assessment. We're asking patients and providers about how things look and whether or not they want changes made. But I believe in the next 6 months we're going to be ready to do a pilot, and we're really excited about that. I mentioned that we're doing this preliminary study where we're looking at some outcomes that we're going to hopefully be able to track before and after we implement the app. And these are all outcomes related to patient quality of life, patient acceptance, readiness for discharge, and their feelings about the discharge process in general. So we're establishing these sort of benchmarks that we're going to be able to measure once we implement the app, but we're all very excited that it's actually coming to fruition. And to be able to say that we've had continuous funding for 2 years now and are going on 2 more years of funding is really, it's awesome. I think the best way to talk about this is to imagine a scenario where your son or your daughter is in a car wreck, and let's say they take some important medications that if they don't get them, they'll have seizures or maybe they'll get a blood clot. And it's very critical that those medications be administered. And let's say, unfortunately, they have a head injury and they're not able to communicate when the paramedics come to them and give them first responder care. I think that you and I, as mothers, would say, I'm willing to give up their privacy so that we can give them the very best care possible and prevent a potentially preventable, very serious medical event that could be a sequelae of them not getting the treatment that they have, or because they got a certain medication before this crash happened. We routinely have elderly patients who are on Coumadin that come in with very serious injuries, and if we only know that they are taking Coumadin, we can initiate a treatment that could potentially be very life-saving and work very quickly. But if we don't know about that, any bit of delay can result in a very serious problem, lots of complications, or potentially even death. So I think if we put ourselves in a position where we think if there's a way that we could prevent an adverse event from occurring because some piece of information about someone's medical history or medication administration history isn't known. I mean, if we can prevent that, I think that that trumps any sort of privacy that we walk around with. Nobody is willing to give up their life for privacy. Now, obviously, not every situation is a life-threatening situation. But I think that you may have experienced this when you've gone to the doctor, that if you go see a specialist, if your records don't get transferred from your primary care doctor or from whomever sent you, like the emergency room, let's say the emergency room refers you to somebody, if that specialist doesn't receive that information, they have to start all over again. They have to maybe even order the same tests that you had before. I don't know about you, but I'm also willing to give up that amount of privacy if I'm going to be able to have a better care facilitated by that practitioner. I would be even willing to say that there are probably a lot of people out there that are more than willing to give up any sort of privacy for that transfer of records, beyond the secure transmission from doctor to doctor, if that's what it would take to be able to make that more efficient. What about holding your own medical records, and having your own data for yourself and keeping that something as you own, and then you can share it. You can choose who gets to have that information. So I think that there are a lot of questions that we need to ask ourselves about the HIPAA, which is the Portability and Security Act that was enacted way back in the Clinton administration. We need to ask ourselves about whether or not this is really a viable kind of rule-based system that we should continue to follow, because does it really facilitate the kind of care that we want to deliver in this country, or does it make it more convoluted, more difficult, and potentially more dangerous? I'm not here to say that privacy is not an option, but I think that we need to readdress this issue more seriously in the public and discuss it so that we can move forward instead of moving in circles as we have for the last 15 or 20 years. I mean, the electronic medical record really has not seen its full potential, and a lot of it is because of this information sharing problem. That is such a wonderful question. This room that we're sitting in right now is the room where we have our division meeting every week, and we routinely will discuss new evidence that comes up so that we can try and incorporate that into our practice. We value that very much. It's said that it takes about 17 years for evidence that has been generated to actually make it into practice. And we all felt viscerally like, oh, this is so terrible, this is the worst thing, that it takes so long for us to enact something that works in a clinical trial. But in fact, in the last 3 to 5 years, a lot of the things that we put into practice within the last 10 years have been debunked. All of these processes for controlling glucose in the ICU very tightly, directing resuscitation, using blood and ionotropic support, the early goal-directed therapy that was shown so beautifully to work in one place has not been reproduced in others. And so, although we feel somewhat discouraged, we also feel like we have to follow the evidence. And as people reproduce or fail to reproduce the findings of others, when it's disseminated into practice, we understand that a lot of the things that are done in clinical trials, frankly, don't work the same way when we do them in the real world. And in fact, this is what I spent 3 years studying with the Comparative Effectiveness Research Award, was this idea of how do things work in the real world? If we actually measure things after they're implemented, what are we going to find? And, we all have these conceptions. I mean, my bias right now is that mobile technology has to be implemented within our care system, and it's really in its infancy. Maybe we'll find in 10 years that all of these ideas that we had about mobile technology are actually wrong, and it wasn't the best way to administer care to our patients. But I think that, as we move through the development of healthcare over the decades, I think back to those old TV shows on like Marcus Welby, where he would take his black bag and he would go to everyone's house and he would arrive and everyone would be so glad to see him. He had a relationship with his patients, but he also had this continuity of care. We've lost much of that connection to our patients for many, many different reasons. We've become super specialized, we are relying on technology, we have these little silos of care where we do this and you do that and I don't take care of that problem. How do we overcome the structure that we've created to be able to continue to reach people? Well, I don't think the answer is that we all go back to carrying a black bag. I certainly don't think the answer is that we rely on the telephone. And that's basically what we do after people leave the hospital. So solving this post-discharge conundrum, I think, is going to involve technology because we simply don't meet people personally like we did before. But I think that the acceptance of social media and the acceptance of mobile devices by the general public has been so broad. And in fact, a lot of us who are in healthcare are very devoted to our mobile devices as well. And trying to incorporate them in a safe, secure way so that we don't unintentionally share things with people that shouldn't see them, that we're not spreading, somebody's dirty laundry out to the public. I think that those are really important safeguards. But the idea that we couldn't freely share information from provider to provider or even from patient to provider because of some rules is really frustrating. So I think, there's a balance here. You asked me about, developing evidence and following evidence, and I managed to find my way back to mobile devices again because I think that we need to generate this evidence. We need to talk about it. I'd like to say that I'm immune to that, and in some ways, working in a public hospital, we are not devoted to generating revenue as our first goal. We're nonprofit, so we don't have to think about the bottom line as the only reason that we exist. Not that for-profit hospitals feel that way either, but I think there's much more of an emphasis on, well, if you don't have insurance, we're not going to be able to provide you with this kind of care. When someone walks into my clinic, it doesn't matter if they don't have insurance. It doesn't matter if they don't have Obamacare. It doesn't matter if they're on charity care. They get the same treatment regardless. So I think we're a little bit insulated as a public institution from that attitude or that gatekeeping. But we're very aware of the fact that we're in the red as a public hospital, that we do serve the community, but we also need to be fiscally responsible. And I think as each year goes on here, we're more and more aware of what our volume is, how many patients we see, what is our commitment to serving the community if we can't keep ourselves solvent. And so I do think that it is difficult and frustrating to imagine a time where we wouldn't be able to care for people. And I think that when that day comes, I'm going to have a really hard time, because that's part of the mission of this hospital and why I work here. And it's very satisfying to be able to care for people that don't have the opportunity for preventative care, or maybe didn't have an early diagnosis because they couldn't go to the doctor. Even taking care of people that have been harmful to themselves is part of our mission. Everybody deserves to get the highest standard of care possible. And I think if you feel that way, you work in a place like this, and you don't focus on what is the bottom line. And we get to be sort of insulated from that. The change in the insurance structure in our country is starting to change who we're caring for already here. We're seeing more people that do have insurance, but overall, I think we're seeing fewer patients in the last couple of months. And it's interesting that it's probably because people that didn't have insurance before and had to come to Harborview are now going to other providers because they have that as an option. We still are here to serve the community, even if people don't have insurance or Medicaid or Medicare. And I think we will always serve that population. But I do hope that we will continue to serve people that don't have to come to Harborview because it's a wonderful place to work. I mean, the mission of this place and the way that people are committed to serve here is beyond any other place I've ever worked. And if people in the community could see that do have a choice of where they can go for their health care, I think they should think long and hard about coming here, because we do provide some of the highest level of care in the city, I think. Well, my children always wear seatbelts. They always wear helmets. I make my husband wear a helmet when we go skiing. I mean, I don't mean to be flip, but of course I'm pretty risk averse when it comes to the things like that. I think on a deeper level, I hope that my children see that I've made a conscious choice to work in an environment where we serve everyone. And that I do see life and death, and we talk about that at home sometimes. You know, when I'm on call and they hear that something bad has happened, like I was on call the day that the landslide happened in Oso. And so my children know that part of my work is to care for people that are severely injured and sometimes who don't survive their injuries. And we do talk about that, and I think it's a really important part of my family life for them to understand that service is essential, that we all are human beings that deserve respect and care. And I want them to grow up in a place where they know that no matter what happens to them, that there's going to be somebody to care for them. So that is really how I think it affects my life. Now, you know, I wear all these different hats. Sometimes I'm an elective general surgeon, and I get to do wonderfully easy, straightforward general surgery cases where the patient comes in and goes home the same day, and they come back to clinic a week later and they tell me, "Oh, I feel so much better, thank you." Sometimes I work in the ICU, and I actually end up caring for families whose loved ones are not going to survive. And honestly, those encounters, as deeply moving and difficult as they can be, are some of the most satisfying, because you know that you're doing something that is going to stay with that family for the rest of their lives, even as their loved one passes away. So I have this really stark contrast in the work that I do. clinically. And then there's, the research hat, which is so fulfilling and so rewarding and very frustrating. So, it all sort of balances out. Amidst all of that, I'm training people to do what I do. And so I try and talk about my experience, not only, based in evidence with our trainees, but I also talk about my own personal experience of what it's like to fail, to do things and have to deal with the consequences, to have complications, because we all do, to have patients who die, to work in very difficult and stressful situations and have to move on and have to care for the next patient just as diligently and with the highest amount of quality as you did the patient that didn't make it. Those are things that are really challenging. And I think, if you find a way to deal with those challenging moments, you really are able to have a very fulfilling life. I can't imagine doing anything else. I absolutely love my work. I love Seattle. I'm really devoted to this community. I did not grow up here, like I mentioned at the beginning of our interview, but I can't imagine living anywhere else right now. And I think that commitment to community and family and this community here that I work with is really something that drives me forward every day.